All right, good morning, everybody. And I guess I don't think we have any members of the public on so far. I only see one participant, which is probably us. So I'm going to call this meeting to order. To get started, wanted to introduce our newest board member, Brandon Blake. Welcome.
Thank you.
I don't know if you'd like to take a couple minutes, tell everybody a little bit about yourself.
Sure, I'll take a stab at it. So member of a resident of Jefferson County, moved here 7 years ago with my wife and 4 kids, living out off of Flowing Springs Road. Been in healthcare operations my entire career, home health, the post-acute care space mostly. I just kind of got a point in my career where, other than just kind of having a job and a career and providing for my family, I just felt kind of this pull to start serving. And what more can I do? How can I use my experience background to solve problems, maybe at a higher scale? I saw the posting go out. I'm like, what do I have to lose? I really didn't know kind of what it would look like or what would happen or whether, would work out. But, I always learned, if you don't swing, you never hit the ball, right? So I took a swing and here I am. I'm glad to be, I'm glad to kind of just contribute, learn, help provide solutions to problems. So I look forward to the journey. It seems like 5-year position. So there'll be plenty of time to kind of dig in and learn and help. So thank you.
Welcome.
Thank you.
All right.
Sorry.
Go ahead.
Ann, Karen,
Elliot,
and these are the 5.
This your co-board members,
Co-board.
yes.
Okay, great.
Have you have a team to get the bylaws and?
Yep, Gino did send that to me. I'm still kind of working through that and trying to understand it all.
Okay, well, there'll be a quiz at the end of the meeting.
Well, it was nice working with you all.
Yeah. All right, well, thank you.
Yeah.
All right, review of the agenda. Anybody have any questions? Requests to reorder? Hearing none, we'll continue and then we'll start with the approval of the July 8th meeting minutes.
The only question I have regarding the minutes has to do with, there's no record of the vote to change the fee. Because didn't we vote to change the fee? Or
No,
was this-
no, to put it.
We did that. You guys did it.
it.
And I think I was here, not remote. Wasn't
I think you were.
I? I think I was too.
I'm not sure.
I don't remember.
I was remote.
But there was some.
We'll look at, we will look at
We
the.
can check the
Of
video and
proposals.
make
Oh.
sure that that's recorded correctly.
I know
Alrighty then.
Elliot was not here. He was traveling,
Right. that's
Yeah, he was remote.
but I'm pretty sure.
I was remote. The meeting was
Maybe
really
the-
short.
You were
Gotcha.
remote.
I was.
We have our hands
It was a
backwards.
very.
Sorry, we have our hands backwards.
So hopefully,
That's-
this setup will allow us to see on the video who it actually is.
Yes, and the names and everything.
Yeah,
Yes.
it's a little.
So with that change, I move we accept the minutes.
I'll second.
All those in favor say aye.
Aye.
Aye. Minutes approved. Public comment period. I don't think we have anybody, so we'll just move along. Starting with the election of the Board of Health officers. It's our annual re-up for chair and vice chair.
I would like to move that we have Karen continue as chair and Elliot as vice chair.
Would have to be formal nominations for both.
Do they need to be separate?
They need to be separate too.
Okay.
Oh.
I move that we nominate Karen as chairman for the next year.
A second.
All those in favor say aye.
Aye.
All those opposed? None. Thank you all for your confidence.
I would like to move that we nominate Elliot as vice chair for the next year.
I second.
All right, thank you. All those in favor say aye. Any opposed? Nope. Thank you very much.
I would just say, I did vote no.
Oh, you
Just
did,
from
I'm
the
sorry.
standpoint of I don't know either of you, and I don't want to vote for a change my first time. It seems like it would pass
You
anyway.
you can also not voting.
Just not vote,
Yeah.
okay,
So what would you like it recorded as, no or?
a non-vote.
No.
Two for us.
For both,
2 for us.
for both.
Oh, sorry,
You'll abstain for both.
abstain.
Okay.
Abstain.
All right, and next on the list is, it is time for the reappointment of the county health officer, which is Dr. Reedy. Do I have a motion on the floor to reappoint Dr. Reedy as our health officer?
I move that we appoint Dr. Reedy to continue as our county health officer.
Is there a second?
A second.
All right, all those in favor say aye. Those opposed, non-voting, motion passes. Thank you so much for your service and continued service. All right, moving on to unfinished businesses, update on vacancies. Sanitarian.
So the sanitarian, Jen's last day was last Friday, August 5th. And I had one interview for her vacancy yesterday, and I have 4 more scheduled for next week. So
Okay.
hopefully we'll have somebody soon. They will miss half of the sanitarian training class. So I've talked to the state about what that means and what they'll be required to do. And it looks like they will, for whatever part of the training class they do attend, they will be allowed to inspect those types of facilities. And then they still won't have their licensure until they complete all training hours, but they will be allowed to do some inspections over the next year until they can take the rest of the sanitarian training class, because that started the first week of August. So they're on the second week. My 2 new sanitarians are in the second week of training right now. So
And-
right now it's just me and Lexi. So we're very short staffed, and we have Lexi doing most of the septic work while I'm doing the food work. So and managing other things, so.
And does the new person have any kind of sanitarian background coming into
No,
this?
I advertised for sanitarian 1 and sanitarian 2. I got 0 applicants for the sanitarian 2, which would have required 1 year of experience as a sanitarian, so no.
Gotcha. All right, any other questions? Okay. The LPN?
So the LPN position is going to be reposted. I had hoped that we had had one. She dropped out for personal reasons. And so we're reposted.
Thank you. Social worker, I guess also.
So social worker, we did have an applicant for that. I've reached out and just haven't received a reply yet.
By the way, that's going around a lot in areas where people get selected for posts and
Yeah.
then they suddenly demur, so it's,
Yeah.
It's the market,
It's okay.
although I'm hearing signs of slowing, so.
We'll fight
hopefully
it
that'll-
like we always do.
Hopefully that'll sort itself out. All right, and then next is Elliot's favorite topic, the bed and breakfast proposed fee change update, discussion and action. So are you gonna lead that?
So no, go ahead. I just wanted to let you know that in your packet, there is the 3 public comments that we received through the Board of Health email. I'm sure you probably saw them when they came through, but just in case if you want to do any review and discussion about in and around those, they're available to you right there.
Do you want to read them into the record or just,
Can we just post them as part of the record?
yeah, they're already part of the packet that I
Right.
think is.
I think that's
Yeah.
appropriate.
So
That's
I'll
fine.
make a motion to make them part of the record as written.
Sure, I'd be happy to post all that then
We
on
have a
the
second.
website.
Second.
All those in favor say aye. Aye.
Yep, we'll
Any
post it.
opposed? Thank you. So does anybody have any questions?
All of the comments were in favor of reducing the food establishment fee for bed and breakfasts,
So
so.
Brent, just in case you're not super familiar, Gillian is the expert to discuss it real quick.
So we were trying to come up with something to make it, we have a lot of short-term rentals that we just recently found out that we are supposed to be permitting, so we've been working on getting those permitted, and there we've had a few, we had one person complain about the fees for short-term rentals and bed and breakfasts. Bed and breakfast, we're basically having to pay their $60 permit fee plus a $125 food establishment fee because they serve breakfast at bed and breakfast. And short-term rentals, we're only having to pay like $125 permit fee for the year. They both have plan review fees for new ones of $125. So at the 2 meetings ago, we discussed, made a motion to put out for public comment that we would reduce the bed and breakfast food establishment fee from $125 to $65. So then they're paying the same amount as a short-term rental would be for both of their permits. And they also, the board also said that they wanted to go ahead and waive the fee, the plan review fee for short-term rentals for 90 days. So that's going through September 15th to get them, motivate them to go ahead and get their permits through our office. So, and we've been trying to advertise that. It's on our Facebook page and our website, and it's out there in the community. I've spoken at a couple meetings on short-term rentals and our requirements for them. And we're trying to just reach out to any short-term rentals that we're aware of that are not permitted, so.
How many have we gotten through that process?
I am not sure. I didn't get that information from Patty, but I know she's been working on it. That we tried to get a list from Airbnb and they would not give us a list with contact information. So we have been sending individual messages to the ones on the Airbnb website. We've been getting some people responding that way. Most people are positively responding and going and submitting their applications. We have quite a few more that we've permitted since advertising everything and reaching out, so. But still not near the number that we know we have in the county, so.
Is it your thinking that the waiving of the application fee might need to get pushed a little bit more?
I'm not sure that we should continue to do that. I really think that most people are aware. I don't think it's an awareness issue now. So I think that basically that if we allow it to continue for 3 more months to keep waiving those fees, that I don't know that it's really going to get additional applicants, and it's also not, there's no benefit to the people that went ahead and did it when they were supposed to, when they should have, like when they found out. So we've had like at least one person tell us it's advertised on his website that the whole house is for rent, but he said that he that's his primary residence. So we're getting things like that too. So.
But Brandon, the concern is with the bed and breakfast and reducing the fee is that if bed and breakfasts have to pay so much more for permitting because they serve the breakfast, that they'll simply convert to the quote unquote, Airbnb style of operation, and we'll lose that kind of attraction in our county because tourism is 1/3 of the employment in Jefferson County. So we want to make sure that we don't penalize, an integral part of our economy.
I see.
And it's the largest industry overall.
Absolutely. Hospitality and tourism is the largest in the county.
Okay, that makes sense.
Some
I appreciate
people-
the background and thank you.
I'm thinking some people are not as busy, so they don't think paying like $200 some worth of money is not, as justify their business. Like if they only have 1 or 2 rent a year.
And that's
But
an annual fee,
But the
I'm
plan
guessing?
review is only for the unoccupied homes, right? It's
The-
not,
The plan review, the fee applies to almost all of our establishments. So it's when they first open, so we can make sure that their plans for what they're doing fall within regulations. So
but it's only a one-time
it's a
application
one-time, yeah,
review.
exactly. So.
Could you,
So we do sometimes charge it again if your permit's lapsed for 6 months, so then it's like looking at everything again, so.
maybe a quick idea of how, of what is required, what type of short-term rentals are required to be permitted? Because
So short-term rentals are only required to be permitted when it's not the primary residence of the owner. So when they're basically just using, and when it's a short-term rental, like there's people that are renting it out, renting some out as apartments, and we're not getting involved in that at all. It's when it's an actual short-term rental, they're renting it for a couple nights to a week or two. So we do the permitting of that, those facilities, but when it's their primary residence and they're renting out rooms in there and they're not serving breakfast, they don't need to be permitted. If it's their primary residence and they're renting out rooms and they are serving breakfast or other meals, they do need to be permitted, so.
Okay.
And this is all decided by the state, by the way. It's not decided by us.
There's a bunch of different
Those
definitions for
definitions
these
are state
lodging
definitions.
facilities, yes, and the short-term rentals or Airbnbs and Verbos, they all fall under the definition of a motel in our general sanitation regulations, so that's why we're regulating them.
What's the scale? I mean, what's the volume that you're looking at? I mean, is it maybe hard to
So
tell?
there's really not that many bed and breakfasts, so this fee's not going to be a big impact. This fee reduction won't be a big impact for our health department. And that's another reason we decided not to change the short-term rental fees, because that would be a big impact, because once we do get them all permitted, we're told there's like 400 in the county. We have a lot, so.
And how many are permitted so far?
Like a fraction of that, a small fraction.
40 to 50
Yeah.
at this point.
Okay.
what
So
I've been
maybe
told.
next month you can tell us how many that you've increased with this
And like the
little
rate.
promo of having a 90-day waiver and
Okay.
in
Yeah,
consideration
I
of
can
whether
do
we
that.
want to do it again.
And are we, sorry, I'm thinking of process here, but with because the CBB receives a portion of the tax, or, gets the hotel, the bed tax essentially. Do they know who those are coming from, or do they just get it in lump
We've
sum?
tried to get a list from them too, but we haven't been able to.
So I emailed and spoke with Annette yesterday,
Uh-huh,
and she said that that's not something that she's ever been provided.
okay,
So she has no direct knowledge of who's submitting or who's remitting the bed tax.
So
And
Patty's
that's then coming to
actually
them.
reaching out to the office, like the county clerk's offices, because they do the business licenses. And they usually tell them when they get their business license what permits they have to get, who they need to contact. So we're making sure that, one, they're aware that they do need a health permit for these short-term rentals, that they need to check our office for that, because before they were telling them they didn't because we weren't requiring it before.
right.
So, and also to see if there's any way that they can provide us with a list of places. So we're reaching out wherever we can to try and get a list with contact information, but right now we don't have anything like that, so.
Okay.
Um,
I was just gonna add, I think, if I remember right, it's the platform itself takes the tax and it goes to the state, and the state gives it to the counties.
Right.
And that's why it's
I
kind
think
of hard
that's
for
right,
them to
yeah.
get the information.
I think you're right.
have we satisfied the requirement for the public notice? Is it-
Yes,
Okay.
Yep.
So that means we can actually vote on it today?
yes,
I make a motion to vote on it.
okay,
Let's clearly define what we're voting on.
yes, so.
Oh,
The 120.
I'll let,
So your motion should say that you're making a motion to reduce the food establishment fee for bed and breakfast from $125 to $65.
that's the motion that
That's the yearly fee.
Yes, if it's the permit fee.
yeah, annual permit.
And I
Yeah.
second that.
All those in favor say aye.
Aye.
Any opposed? All right, motion passes. Thank you all for all the work on that.
So
And thank you
was
to
all
my
given.
colleagues who brought it forward. I was absent actually from that meeting, so thank you so much. All right, heading over to new business. Charlie.
All right. Good morning, everyone. You should have received your financials. I'm gonna go over the 6/30/2020 financials. I do have a small change in that. In late July, we did receive a fifth state allocation of $22,000. So that brings our surplus for the fiscal year to $62,000. To go over some key metrics, bank balance, $598,000. And that puts us in compliance with the reserve requirements. We have excess reserve of 325.
Great.
Our accounts receivable stands at $165,000. 75% of that is West Virginia Treasury.
75% of that is West Virginia. Okay, got it. Thank you.
And average days to pay is 25 days as of 6:30.
Which has actually gone down
I
quite a
was
bit.
gonna say that's.
Yes, and it does get better in July. To kind of give an overall picture of your fiscal year end, your total revenue was over budget by 30%, so that's positive. And that is excluding the retention incentive that was received. Total salaries and wages, that was above budget by 6%, but your operating expenses were below budget by 4%. July statements, I'm gonna start here with the key metrics. So your bank balance as of 7/31, $631,000. Again, that puts you above your reserve requirements by $335,000. Total accounts receivable as of 7/31, $100,000. And 71% of that is West Virginia Treasury. So that went down.
So say that one more time, 101,000 AR?
100,000 AR.
100,000 AR and 71% is the West Virginia Treasury. Okay.
71,000, yeah.
Oh.
And so as of 6/30, the West Virginia Treasury receivable was almost 125,000. So it did decrease.
What makes up the remaining in terms of the
It's
The other
receivables?
mainly
29.
threat prep, I believe.
So grant reimbursements,
Okay.
Well, grants.
grant reimbursement on the threat prep side.
So West Virginia, are those grants coming through the state as well, but they're not counted as treasury?
They are counted as treasury.
They are Treasury.
They are treasury. They're counted as West Virginia Treasury reimbursements. And it's state pass-throughs from the federal government.
Right. Okay. So then why wouldn't it be 100, like whatever, because we've got 71% from the West Virginia Treasury is outstanding, so there's a remaining 29% in accounts receivable.
Oh, it's various.
Okay.
Oh, sorry, I misunderstood the question.
Okay.
Some of it can be clinical billing,
Insurance. claims.
insurance claims, that type of stuff,
Yeah,
exactly.
it was nothing significant.
Okay.
Yeah, just small balances.
Gotcha.
Sure, I mean, if you got over 71% from one source, which is what we know is our primary source of revenue.
Yeah, we should include it.
You want the full accounts receivable detail?
Just a broad number, like where it's coming from.
Yeah.
Is that okay, Karen?
It's really easy for me to print out accounts receivable summary, but it is like 2, maybe 3 pages long.
Or do you just want to have like an other under West, so percentage of
Right.
accounts, West Virginia
Right.
Treasury, and then just maybe add a line item of other, I think is what Ann is asking.
Oh, okay.
Just
yeah.
say other, because in case there's like maybe a category that emerges, maybe there's something that comes from a foundation or whatever, so.
Absolutely.
What you might want to do is like, if it's over 10% of AR, kind of line item it and then put everything else maybe under 10%. And it might be that nothing other than the West Virginia Treasury is over 10%. Just as a way to, not make it 3 pages, but allow us to see anything that's kind of getting over a certain threshold. With the West Virginia Treasury, just as, as the new guy coming in, is that a monthly check that you get from them? Is it quarterly? How does that?
It's quarterly, and we've billed for it. We just have not received the money.
Okay, all right, so this would be dollars that you've billed but haven't received yet.
Correct.
Got it, okay.
All right. So I'll make those changes to the key metrics for next month. To go over the financials, we had a deficit of $50,000. Again, these are preliminary, so maybe there's some billings that have not been reflected in here yet. Revenue, $18,000, salaries and wages, $63,000, and operating expenses, $6,000. So if we compare that to your budget, your total income is below your target right now by 7%. Salaries and wages below budget 3%, and operating expenses below budget 6%.
Any other questions?
So historically, we've been running roughly $30,000 in deficit every month for years.
Okay. So this is kind of,
This is the area we need to work on, that to close that gap.
and you're talking about deficit to budget or operating deficit?
Income and
Got it.
expenses.
Okay.
Yet
So that
the,
-50 is, the average over the past couple of years has been -30. Okay, that's helpful.
But some of that is due to the sort of reimbursement rates.
yeah, but I mean, by the end of the fiscal year, which is June 30th, the revenue was 30% over budget.
Right.
So
It equalizes out. It's just,
we took in more money than we had budgeted. So that sort of compensates for some of the deficits in the previous year's budget are compensated for that.
But that is this year though. Historically, we never make up the money.
Right.
It's to be seen.
Fiscal year 21
That means
was
things are
also
improving.
a surplus.
Well, that was
Along with
COVID.
fiscal year 22, so the past 2 fiscal years have been net positive.
Right, but that's COVID money. It's different.
So it's July to June is the fiscal year?
Yes.
Yep, July 1st through June 30th.
July
We're
1st.
operating in fiscal year 23.
Okay. And so fiscal year 22, that was the June 30th, that has the year-to-date, the full fiscal year picture and that. Okay, I saw that in the packet. I don't have it here in paper, but from a profit and loss, where did that land? Was a net positive for fiscal year?
We're not a profit-making
Yeah.
organization, so we call it
Not for profit.
surplus and deficit.
Surplus, okay. Sorry, so this is.
Welcome to government, yes, welcome to
government. What is it? Surplus and deficit.
Right.
Okay.
And there, in July, we did have a small change to the 630 numbers. So in your packet, it's gonna say there's a surplus of
Yeah,
$40,000.
I see it here.
But I made the change this morning and it's actually $62,000.
Okay. All right.
and the way that we standard operations that we have here is that we get both the final numbers of 2 months before basically and the preliminaries of the previous month. So June 20 is what the June 2022 numbers you got in your packet is what we're going to vote to accept. July, we don't do any kind of that until September because we just look at the preliminaries, but there's still like outstandings and whatever, but it gives us a glimpse into the current
Got it.
of what we need to look at and if there's a flag or whatever the case may be.
Thank you, Karen.
Any other questions on the financials?
I move we accept the June 30th, 22 financial reports.
Second.
All those in favor say aye. Any opposed? You're opposed? All right, record reflect that Ann Wynn is opposed. Thank you. All right, and moving on to agency activity reports. Starting with the health administrator.
So fairly rosy financial reports, so we like that. That makes my job a lot easier, and certainly your job of supervising me a lot easier. So I don't really have too much else to say about that, but we've been within budget this past year, and I'm happy to continue to try to do that.
How's the internet project going?
So we have now received our main router from the state. Like I said last meeting, I'm project managing this for the state, unreimbursed, of course. And a lot of the parts are in, but it's still probably going to be October. You know how the state moves. I've been trying for this for months and months, but we're closer.
Appreciate the perseverance. All right, well, nothing else. Move on to the health officer, Dr. Reedy.
We'll start with Evan, who's our epidemiologist, is going to give the COVID report.
Yeah, so I'm just gonna kind of give a
I'm
brief.
sorry, what's your name?
Introduce
So my
you.
name's Bevan, I'm an epidemiologist here. I recently graduated from GW, so. Yeah,
She's a
so maybe
master's in
you guys can have an
epidemiology.
overview of COVID, what's going on, changes, for the past month.
We surf the internet?
Bear with me. Oh, get out of here. Okay.
All right, so this is just gonna kind of reflect the changes that we've seen from the last.
Are you on screen share?
So this is looking at June 9th to August 9th. You can kind of see a major shift from green to red. Green being low, yellow medium, and then red being high as the number of cases that have come in. Next slide. Can I do this?
Yeah, that's fine.
Okay. So this shows strictly the state. You can see kind of the same trend that you see with the entire country, a big shift to red. Should be noted that we are moving towards flu season, so that could kind of account for that as well. And then strictly looking at West Virginia compared to Jefferson. So Jefferson County specifically has 231 weekly new reported cases per 100,000 people, compared to the 336 in the entire state. For Jefferson County, 14.5 admissions per 100,000 to the hospital. And 4.6% of hospital patients in hospitals are COVID patients. And then 77.3% of the population in Jefferson County has received at least one vaccination.
Did you say 77%?
Yes, so 77% of Jefferson. For the state, it's 65.9. All right, and so looking at our community level risk level matrix, this kind of just shows what I went over on the last slide, just visually. This shows the 231 new cases reported weekly. So you can see here, this is kind of where we're at here, compared to how we were last season. It's definitely an increase. And then it also should be noted that due to the high level of home testing, these numbers are not 100% completely accurate. A lot of home tests aren't reported. So it's believed to be much higher than is actually displayed.
Bevan, if you can, so it's actually the 2nd August on the map was last year. And in July, we were great. And then in August, it started
Okay.
going up. So,
August, right?
so we're hopeful we're not going to go up because we're actually at pretty high levels now.
Yeah.
Our numbers now are, last year we did not have home tests. So the only way you knew it was getting a commercial test of some sort. Now most people are doing home tests and not going to a lab to get tested. I've heard an estimate this week from Dr. Clay Marsh that it could be 7 to 10 times as many cases. So if you look at that line, the number we have is much greater than our published, solid numbers.
So when you say 231 per 100,000, so that would mean in Jefferson County, that would be about 150
Well,
actual cases.
yeah, so the way that number is gotten is, so obviously Jefferson County doesn't have 100,000 people. So
That's
it's just
about
based on
60.
like the percentage. So it gives you the number within 100,000, but it's the percentage of.
That's what I'm saying. So the actual number of cases would be more like 150,
Correct.
something like that.
Yeah, so
Identify.
something.
60%.
60% of that.
Right, okay.
Okay. So this is looking at specifically at a hospital basis. So this looks at Berkeley and Jefferson Medical. Obviously, you can see that Berkeley is seeing a lot more hospitalized COVID cases than Jefferson. Is also a bigger hospital. And it's kind of showing the same trends that was seen on the other map. It is kind of increasing in the number of hospitalizations, and that's something that I'm seeing as well. And they're kind of parallel for the most part in that increase. Okay, and this looks at the daily reported COVID cases per 100,000 once again, but it also looks at the US trend. So they're all pretty similar in shape and rise and increase. It should be noted that West Virginia is higher than the US average. Jefferson falls about, at this point, about the same. Same thing for the hospitalizations. West Virginia is seeing a big increase in hospitalizations compared to the US average. Jefferson County is about the same as the US, but it still is increasing, and you can see here it is increasing pretty drastically. All right, prevention steps based on COVID-19 community levels. So that's the map that was at the beginning with the green, yellow, and red. This kind of just goes over the prevention strategies that should be in place to kind of help you lower in color. So right now we're high. So this is all recommended by the CDC. I'm kind of just relaying what they're saying. So wear a mask indoors and on public transportation. Public transportation is a big one. Up to date with COVID vaccines and getting tested when needed. There are a surplus of home tests, so you can get them at, Walgreens, CVS, all of that. And then additional precautions may be needed on an individual basis, so that's something that you can seek advisement on. All right, COVID vaccines. I'm pretty sure I just skipped a page. Okay, we'll just scroll it. Okay, so a percentage of vaccinated residents in West Virginia. So the total for West Virginia is 65.9, whereas in Jefferson specifically, it's 77.3. Which is obviously higher than the state, which is good. It's still 77%, so there is still room for increase, and that's something that we provide here at the health department. So if people call in, we're able to give those vaccines. So, all right, and then I'm going to hand it off to Dr. Reed.
So before we get to monkeypox, just a few things on the COVID. Though the numbers of actual cases we no longer can accurately tabulate, that's across the world because of the home testing, which are readily available, which is good. The numbers of people hospitalized with COVID, either from COVID or incidentally having it at the same time they happen to break their leg or whatever, is a more solid number in that that's being measured the same way as it was before. So our numbers of hospitalized are not how they were earlier with similar numbers of cases. So that's good. Same with deaths, as they are remaining relatively low, not zero. The difference in the graphs showing hospitalizations in West Virginia versus Jefferson County, I don't know the actual reason. One of the questions is whether the vaccinations are the major reason for that. In the Jefferson County is one of the best counties as far as the most people vaccinated compared to other counties. West Virginia as a whole is one of the lowest number of vaccinations in the nation. The group at greatest risk are those who are older, and we can use 50 or 60 as a cutoff, because that's where we see, that's where most of the hospitalizations and deaths are in the older age group. So my focus is trying to get those people vaccinated if they never have been, people who have not wanted the messenger RNA vaccine and have not gotten any vaccinations. There is the Novavax vaccine now, which is a more traditional vaccine made with the antigen that the person gets injected with, as opposed to the RNA. So that is available now, and we do have that here. The other people who have already gotten their vaccine but aren't up to date, either meaning they never got their second dose, or more commonly, they got their first 2 doses but never got their first booster, their first 2 doses being more than a year ago, their immunity needs a boost so that when they get infected, they're able to handle it better. And we do see a difference as I look at individual cases who are in the hospital. The number who aren't vaccinated tends to still be an appreciable number of those cases, so there's a disproportion. So that's my big plea. The CDC changed the quarantine guidance yesterday to what is already being done. So it's simply making it in line with how people have ended up deciding what to do. Meaning if someone in this room comes down, tomorrow we find out they had COVID, they would have been infectious at the time they're in here. And we have all these different things of, well, if you were wearing a mask, if they were both masked, if they were vaccinated or not vaccinated, how much any of that matters is hard to know. The reality is, even from the very beginning, people are reticent to either inform other people or to admit that they were in close contact. How do we measure? So you say, 15 minutes within 6 feet. Well, how about 20 minutes within 8 feet? It's so now you no longer have to do that whether you're vaccinated or not. And so the school rules will end up affecting that. If you are infected, it doesn't matter, it hasn't mattered whether you're vaccinated or not. If you're infected, you have to be away from other people or isolate for 5 days. And as long as you're getting better, then you can go back around them, but you need to not be intimate. So you need to wear masks for the next 5 days, not eat lunch with them because you're not wearing a mask. Obviously in places like daycare, that doesn't work. So daycare's, special. So the rules will now be closer to what people are actually doing. Hopefully that will reduce the conflict. There's not as much conflict now. Influenza vaccination season's right around the corner. I wouldn't be surprised if some of the commercial drugstores already have it. So we will be giving influenza vaccinations in the community before the next meeting. I'd encourage everyone to get it. We have not had big influenza years the last 2 years. Probably a lot of that's because of the COVID prevention measures, work on other respiratory viruses. So this year, with those precautions relaxed, things are pretty much back to how they used to be. We expect a bigger flu year, but every year is different. We never know when's going to be a bad year and when's not. Before I get off flu topic, there are three or four cases of swine flu reported in the U.S. In this past week, and all of them are from Jackson County, West Virginia, possibly related to the swine barn at the county fair. The state fair has the swine barn, but it's not open to visitors. The state fair, county fair is this week. So this is not highly transmissible, but it is still something to be concerned about. We do not have any opinion or guidance right now about what's going to happen with our county fair starting in next week, but that's going to be something we'll be watching. So there's always other things to think about.
Avoid the
And
pig
I'm
barn.
always thinking.
I'm always avoiding the pig barn.
Yeah.
That's
Well,
my
and
least
the-
favorite place
you know,
at the fair.
We see salmonella from backyard poultry and
Exactly.
so there's lots to think about when we interact with this world, and you go walking and get bitten by a deer tick and Lyme disease, so we can't perfectly control our lives.
Always wash your hands. Wash your
And
hands.
as I always like to do when you're talking about, not specifically talking about the COVID vaccines, and it's interesting that there's now a non-mRNA version that is out, which I think is promising. We'll see though, because these vaccines, as I point out every time, we do not have long-term safety data on them. And there are studies that have been coming out of Europe, the UK, Sweden. The UK, there are a couple of studies that come out that 91% of the COVID deaths of a certain group that they were studying were vaccinated. And there's another study out of the UK that says that you are 4 times more likely to get COVID if you've been vaccinated. So we can talk about the severity of symptoms or whatever, there are so many questions about these vaccines, and I just wanted to always, I like to put that out there because we don't have the long-term data to support the safety profile of these injections. That's the end of my rant.
Duly noted.
Thank you.
So we'll go to monkeypox, which has come on the scene. As a reminder, this has been around for since the late 50s. It was first discovered, and it seems to have its reservoir in a rodent in Central Africa. But it never really expanded much beyond there. This spring, it was noted in Europe, and now there are, as you can see from the slide, it has increased rapidly in Europe and the United States. In the United States, as of today, there are over 10,000 confirmed cases. Those are confirmed by a test that measures specifically the DNA of this virus from a skin lesion. There are probably far more cases, either people did not, they had a skin lesion, they didn't get checked, or they got checked and the test didn't show it because it's simply rubbing that skin, it's not getting a blood sample or something. They didn't have a severe enough disease to even be aware of it. We have a lot yet to learn about this. This is in the same family as smallpox, not chickenpox. That's a different virus family, but smallpox. So one of the questions is why we're now seeing it spread in the world. One hypothesis is that in 1958, most people were getting vaccinated against smallpox, and some of the older ones in this room were vaccinated in their 60s against smallpox, but not since. And the immunity over those 50 years, has decreased. So maybe we're more susceptible. We do not yet have information yet to know if there's a difference in vaccinated or unvaccinated. Those are mostly age cohorts.
I've heard reports that the vast majority of monkeypox cases have appeared in gay men.
So it is true. Healthcare, we're using men who have sex with men because a person may not identify themselves as gay. But anyway, this is not presently classified as a sexually transmitted disease because there are other behaviors other than the sexual encounter, though. So we're saying close physical contact, but the high risk group right now are men who have sex with men, and the more often you do this, the more often you have that intimate contact, the increased number of chances. This is not as deadly as the usual strain that was in Africa. It seems to be less deadly. Relatively few cases. I've only read reports of a few. The first ones I read were people who actually had very severe immune suppression from other diseases. So they were susceptible to all sorts of things that normally wouldn't affect us. It can be a painful process. We do know from sexual behavior that some men who have sex with men also have sex with women. When you get into the drug using group, and non-drug using, there is commercial sex workers who then go between seeing bisexual and heterosexual individuals. So this is not expected to stay in just the gay group. So we're trying to anticipate what happens. There is a vaccine that was developed for smallpox. Unlike the usual smallpox vaccine, which was a live replicating virus that would actually form a scab here that could be transmitted. This one is, this is a virus that does not replicate. So you get injected with it, your body develops immunity, but it can't, even if you're immune suppressed, you can't get an infection from it. So this is the safer one. There's another one that's available in larger numbers that's effective, but it's the traditional way of scarification with an open scab, open sore that then could transmit to immune suppressed people, could make that person ill, but also has a 1 in 700 chance of causing myocarditis. So that's, though it's available, it's not going to be used as long as the death rate from monkeypox remains extremely low. So it's included in all the summaries, but it's like off the table. The monkeypox, just the cases, just to give you an idea, so we'll compare with, so the US has about 11,000 cases. Washington, D.C., which has about half the population of the state of West Virginia. Now we know there's lots of differences in D.C. And the rest of West Virginia, or just Jefferson County. D.C. has had 319 identified cases, West Virginia 4 as of today. Again, population D.C. is about half. They have had delivered to D.C. about 22,000 doses of vaccine, 22,000 doses because it's a 2-shot series. That's enough for 11,000 people. Whereas West Virginia has had 1,000. So we've had enough for 500 people. The initial rollout of this is to people who have definitely had exposure to someone with monkeypox or in a high-risk situation where they almost certainly did, such as someone who had, so the definition is someone who's gay, or other definitions, and has in the last month had multiple sex partners or anonymous sex partners.
So then you say it's not been classified as an STD, but it kind of looks like it's going that way.
Well, at the moment, so we do not know that the sexual act itself, such as, but it could be other ways of being intimate, but it's pretty hard to tease that out. It's hard enough to get people to
So to speak.
identify. But but yes, it has that, but it's not, we would say that pregnancy is sexually transmitted, but but in this case.
But it's not a disease.
No, but in this case, you can have other intimate contact and transmit it without intercourse. So this is an intimate contact, but there have been cases reported now in childcare. So there are other intimacies. We mentioned how.
Which grosses me out because
The other intimacies can be holding a child, if you have it, if you have sores, and that child is with you. So we have a lot to learn, but
always.
And I'm hopeful, not that this is exclusively in that population, but that it requires really, really intimate contact as opposed to less intimate, because there are only about 2 million doses, 1 million people's worth of vaccine presently available. Maybe a little bit more by the end of the year for 330 million Americans. You'd need 660 million doses. As of this week, they have changed the administration that instead of a regular shot, it's down to a fifth of the dose, but it's given like a tuberculosis skin test, which and there is data that shows that that gives the same immunity. So they've expanded the number of doses available, but that's still going to take care of a high-risk group. But if it becomes that we are all at higher risk, so we don't know, but the goal right now is to try and get as many people in the high-risk group vaccinated so that they are less likely to transmit it to someone else. And then the definition becomes, so who's at a high-risk group? So the current definition is if you know you were exposed, if your partner did get diagnosed. So that's obviously a high-risk group, and the sooner you get vaccinated, the better. The next is those who are very likely to have been exposed, and then the definition becomes those who aren't sure, but they've had multiple sex partners. They weren't in DC, for example, but they could have been. And then the question becomes, say, well, what if you had multiple sex partners in the last 2 months, but not the last 2 weeks?
And then we have no idea.
Well, the goal is for in the future. So are you likely to next week come across that? Because these relationships are not always planned. Same with heterosexual, they're not always planned, they can happen. And so we're trying to, get that expanded to a wider group to protect those who have behaviors that are greater risk. So that is preventive medicine, but we can only get the vaccine that's allocated to us. That's one of our big pushes. So we'll keep you updated on it. We have given vaccines, we have done tests on people.
Any other questions?
I do have a question on the antigen, back to the COVID vaccine that's out
Yes.
there now. Is that available as a booster, or would you have to kind of
It's not
restart?
available as a booster. So some people that have decided they do not want the booster of the messenger RNA, either because they now have had second thoughts and don't want it, or they said, I felt crappy after that, or worse than crappy. I do believe a lot of the people who have not gotten their follow-up doses, it's more just procrastination, which happens in lots of doctor visit things. I'll get to it, but not this week. They're not strongly against it. I do not know if a month from now they'll say, now you can switch and get a booster with the Novavax. That's the brand name of it.
So the Novavax is only for newly
For
vaccinated people?
unvaccinated people,
Okay.
we're gonna start.
Gotcha.
But if you want to switch, you can.
You-
If you have
No.
the
It is not
mRNA.
It is not approved. It's not authorized for us to administer that
By
to
whom?
someone.
Oh, because of
So-
limited, because of the clinicals conflicts, or is it because we have limited supplies?
We're talking about the COVID vaccine.
But
Right.
So it's
authorized by,
because the
Your
emergency
antigen-
use authorization for it is specifies, and it's for those who haven't received it.
but I mean,
Because
who's the authorizing body? What's it
The-
authorized by?
The
FDA.
different branches of the federal government that give us permission to receive.
Well, which one? Which one is it?
Is it
So
the FDA?
my agreement is with the Center for Disease Control that I am a recipient of the vaccine supplies as long as I follow their guidance. If I don't follow their guidance, then I'm violating that contract.
I don't think you understand my question, Dr. Reedy. My question is, you're not allowed to take both vaccine. Let's see, I'm vaccinated with the mRNA vaccine. A year later, I choose not to continue on the mRNA vaccine. So if I choose to take the antigen vaccine, it's not approved because it's a conflict of medication, or
So there-
like
there's
clinical
not, there's not,
conflicts, or is it because of number of vaccine
so there's not yet
availability?
available data to show the benefit in that situation. I believe, based on other information, that this will give the same kind of boost as others, but I don't know that, so that this is not yet authorized. Initially, you couldn't switch from one messenger RNA to another one, but later it became that you could exchange them.
So to clarify though, it sounds like there's the clinical approvals or haven't happened yet.
Right.
It's not a supply issue.
So I hope that later it becomes, go ahead and do it, and I believe that will happen because it gives people more options and hopefully more people that will get their up-to-date boosting.
Technically, the mRNAs act as an antigen in your body. Antigen is just a strange substance into your body, and your white cell would, create, an antibody to get rid of that antigen. So the mRNA is the same as antigen technically.
No, it's not. It absolutely is not. What it does is it tells your body to manufacture a spike protein, and that is allegedly the antigen.
That's
But the
the same thing
vaccine, no, it's not.
Okay.
It's really, really not. It's a whole different mechanism. That's why it's still experimental.
It's mRNA and then vector vaccine is the difference, right?
Yes, so
Okay. Just to clarify for me.
so the difference is that the messenger RNA gives the RNA instruction for your cells to make the spike protein to which your body's immune system reacts.
Right.
With a virus that, if you had a natural infection, you would get other antigens, other parts of the virus that your body would also react to. In theory, maybe that's better. In reality, it may not be. The components of the vaccine are not simply the mRNA or the other components of and so some of what it's mixed with is what makes people feel crummy.
You
They
cannot
actually-
identify the spike antibody or the natural antibody.
But the spike,
You have antibody as antibody, period. You cannot differentiate between the two.
We can, in that if someone had a
They have
natural
to go
infection,
along.
they will have antibodies against the spike protein and the nucleus
But-
protein.
Mhm.
Whereas someone only had the vaccine, it would only had a spike protein vaccine, they will only have an antibody against the spike protein.
Right,
So-
but you have to go deeper to differentiate that
Right,
in the lab.
and we don't know the mechanism and how your body is reacting to the spike protein, because it can keep manufacturing those spike proteins in you like forever.
No, the messenger RNA gets destroyed, that does not replicate in
We'll see.
It's worth the same.
We'll see. We don't know.
and so. Thank you.
All right, Mason,
Environmental.
I'm sorry. I'm so sorry.
That's all right. If you want to skip me, that's fine.
We already gave us so much on the short-term rental stuff. I
I know, I
mean,
kinda
that was
gave
the
a
big
little bit
deal.
of an
That was the
update
big
then.
deal,
I know, so.
Sorry, Gilead.
So, last month, there were 108 total inspections and or site evaluations done by the sanitarians, also 16 plan reviews. And we had 40 animal bite or scratch reports. So only one animal was sent for testing and that animal was negative. So that's an overview of the numbers. And as I said, we are down to one sanitarian and myself, while the other two are in training, and I'm working on hiring another one. So I'm not sure what next month's numbers are gonna look like, but we're doing our best. So we're trying to get it done.
Can you add the short-term rental permits to your report with those things
They
too?
should be,
Or are they?
oh, the permits, yeah, I can add the permits to it, yes. Yeah. We can do that.
I also believe,
And I'll look at what we've done basically since you guys waived the fee. But the fee has been waived since the beginning, really. We've waived
That-
Additionally.
Yeah,
Right, but we went into this year with only maybe 20 or something.
yes.
It was a very
We only
light-
had like 20 when, I think at that meeting, so, yeah.
So,
So I'll look.
so the environmental part of the report here is pages 2 and 3.
Yes.
Okay, so who's going to give page 1?
So the clinical report would normally be the nurse director.
All right.
So she's unavailable for
I
today.
can answer questions. about
So
Dr.
when,
Reed,
but
yes.
when it comes, I notice there's epidemiology on here, that would be prepared by you, right?
it. In the future, she just started.
Yeah.
All right, so she just started, so,
Just started.
all right, so.
And then actually did help prepare those numbers for the epidemiology report, so, yeah.
She's up. And what she's mainly doing is clearing a backlog
Yeah.
of unreported epidemiology
Okay,
to the state. And she's done a great job catching us up. It's a lot of that had been put aside over the last couple years, at least, unfortunately.
We're very happy to have Bevin on staff to help with that.
welcome aboard, when did you start?
It was in the middle of July, I was like 13.
So, and she was working with us before, like, as part of her
Yeah, so I
program.
did my internship here, and then I also was a contact tracer when we were doing that with COVID as well.
Now you- now
very
you're
good-
legit though, right?
And now we're paying her, yeah. She's technically a part-time temp right now, but we're trying to get a full-time position for that.
My
You're-
good friend
So-
graduated from public health, her master's with DW.
Oh, wow.
Very, very informative, very good information source to go to.
No, absolutely.
And your bachelor's is,
Oh, and then I got my bachelor's at George Mason in community health.
Better school.
Well, that's
Something
and mom lives in Charlestown.
But I suspect that we'll make sure that the nurse director is scheduled. But sometimes because of her academic scheduling and stuff, it floats.
Understood, we've got the
Her schedule
paper, so we were able to
Yeah,
review.
you
and I
know,
think if there's-
just what I'd like to do
Um,
going forward is to do at least give a month-to-month comparison, a previous month comparison. I think that would be a little bit more informative for you guys. So that's something that I think I'd like to add in
Absolutely.
going
if you'd like
forward.
to.
I
But
think Elliot would be receptive to that, knowing what the previous numbers were and things like that, or maybe a 3-month average or something like that. We'll decide on that and come with something that's a little bit more informative going forward.
Can I also backtrack back to Gillian?
Sure.
How are we doing in terms of septic systems? Are they like?
We haven't seen really any decrease in the number of permits and stuff that we're doing for septic
And-
at this point.
And are they passing at high
We
rates?
had 3 denials last month, so that number's always written in there, but for the most part, yes, they pass.
Okay.
And often with the denials, they're given an opportunity to get, like it's a denial for a class 1 system, but they're given an opportunity for a class 2. I do think in at least 2 out of 3 of the denials from last month that they were denied for both class 1 and class 2. So there's all kinds of things that can limit them being able to install a septic system on their property. I think one of them was able to get an AJU permit, but others that didn't have previous permits and were trying to get permits on little lots with bad soils or other issues where there's too many wells and septic surrounding the properties.
For new construction, what does it take to get a septic system perk or a well?
So the percolation rate is what everybody refers to as perks, and everybody thinks that that's that if they have a good perk, or they refer to, when people are referring to perk, they're often referring to not just the percolation rate, which you need between 5 and 60 minutes per, so that's what
How much, honestly? So
it's
what are you saying?
It's
Like,
minutes
what's
per
this?
inch, so,
Okay.
so basically it has to go into the soil, like you're measuring the depth that it's gone down, and it has to go down between 5 and 60 minutes per inch. So you dig a hole that's as deep as you want your installation to go, and then you dig 4 little holes like that around the reserve area, but you're also digging a big 6-foot hole that we climb into and evaluate the soils. Yeah.
Wow.
You get to see it
So we
sometimes.
do.
Talk about getting down and dirty, man.
So the soils evaluation really tells us more than the perk rates, because the perk rates are done over like a 6-hour time period by the installers. We don't do those. So we're depending on them to give us accurate numbers for the percolation test results, and that number does help us with sizing the system. So if it's above 30 minutes per inch, then their system's gonna have to be sized a little bit larger than if it were below 30 minutes per inch or 30 or below. And, but the most valuable information for us is what those soils look like in that 6-foot observation pit, so.
Great,
So
thank you.
so many people coming here have never had a septic system and they have no understanding of what it is.
So that was me 20
The
years ago.
septic system is to trap the sewage in the organic part of the topsoil, which, you know, has living organisms, and that then degrades the sewage. But you don't want real sandy soil where the water, the sewage immediately goes into the groundwater. So that's why you have it can go too
Well,
fast.
here, we don't have too much sandy soil
Yeah,
here, it's
but-
more rock.
But you also
Yeah.
don't want it to stay there and
That-
just
that-
stay
that too.
waterlogged for a long time. For the other, you may have a perk test that works, but if there are times when that's a waterlogged area,
Well, the
then
perk
that's-
can be really fast in places where we have the limestone, the karst area soils that we have. So really the better indication for us is what those soils look like when we're getting into those pits, so.
so the waterlogged areas look different too.
Yeah, so the soils turn gray when it's when they have seasonal water table. You'll see grayer soils, and also a lot of times we end up with standing water in some of these pits if it's bad enough. And also just another limiting layer is how much rock you have in those pits and how dense that rock is.
And it's different from acre to acre, or from
Mhm.
10 feet to
Yeah,
10 feet.
I was gonna say on our farm, it's 10 feet to 10 feet.
Yeah, we get arguments all the time that, well, my neighbor was able to get a septic system. Yeah, I understand that, but from what we're looking at on your property, so.
Just going back to the clinical too, when, you know, in the case of the nurse not being here, or even if Bevan's not able to join, feel free to reach out to staff to ask any follow-up questions if you have any curiosities. You know, it doesn't have to be during the month, you know, reach out through Gino if you have any follow-up questions, and he can direct as according.
I encourage it.
All right, any other questions? All right, next meeting.
Mason, you have anything to discuss?
Oh, I'm sorry.
Yeah,
See,
no,
I tried to go to you. I think you were away from me.
Yeah.
Two
You know, I'm just
two big
like
ones, the two
not
big ones.
following
The two
today.
big ones?
Good,
Yeah,
with the two big ones.
So the fire drill and the fair.
So, and also the active shooter training.
Okay, gotcha. So we are doing the active shooter training right now. We had our first 6 staff members go on July, I think the 27th. And then the next one is the 24th. And then we have one in September, the 21st.
Where is it at?
So it's at Summit Point Raceway. It's like in one of the facilities that we
Who
have.
do we contact to like join? Like,
So you
sheriff?
can reach out to me. We actually have spots available at the, you know, for the 24th one or for the 21st one.
She says September 24th.
So August 24th and September 21st. And both of them are from 8 until noon. So,
Thank you.
and we're working with hospice and the Panhandle. We have a bunch of staff over there as well. And then, oh yeah, so then we're setting up the fair we're setting up a booth at the Jefferson County Fairgrounds. And so we are working on providing like our clinical services information, our environmental services information. And we are relying on volunteers to help us staff that booth, and also our community outreach workers, like Larry Togans, and a couple others, so. And we still have a couple of spots available on Sunday and Saturday, if any of the board members are interested in helping
I'm
out.
already there, you see.
Okay.
Already booked.
Once you volunteer, people find you.
All right, any questions for Mason? All right, our next meeting is scheduled for September 9th at 9 o'clock. And do I have a motion to adjourn?
I move we adjourn.
All right, second, and I'll take your second. All those in favor say aye.
Aye.
Clearly nobody opposed. All right, thanks, everybody.
So how was your meeting?
It was great.
Lots of them.
Yeah, it's exciting. Yeah, learned a lot.